So Hodgkin lymphoma is not nearly as common as non-Hodgkin lymphoma. There's only about 7,500 new cases diagnosed in the United States per year. It's very interesting in that there's probably two peaks of Hodgkin's. One occurs in young adults and even teenagers, and then there's a second peak that increases after the age of 50. The only way to make a diagnosis of Hodgkin lymphoma is to have a big enough biopsy sample. This is very, very important because if you get a needle core biopsy, particularly with the most common type of Hodgkin called nodular sclerosing Hodgkin disease, you might only see little bands of fibrosis and you won't be able to make the final diagnosis. So having a big piece is very important. The treatment for Hodgkin lymphoma depends primarily on the stage and whether or not somebody has risk factors. So in lymphomas, including Hodgkin lymphoma, we use something called the Ann Arbor staging classification. It's a fairly simple classification in that stage 1 is any lymph node in the body, stage 2 is 2 lymph nodes but on the same side of the diaphragm, and stage 3 is both sides of the diaphragm, and stage 4 usually means there's non-lymph node involvement such as the bone marrow, liver, or other organs. When it comes to treatment, it depends very much on which stage somebody has, the size of the lymph node that's involved, and then whether or not they have risk factors. And the definition of risk factors varies a little bit between Europe and America, but in general, if somebody has symptoms related to their Hodgkin's, like fevers, night sweats, or weight loss, or if they have some laboratory abnormalities such as a sedimentation rate that's elevated, they would be considered in the higher risk category. When it comes to treatment, for people who have advanced stage disease, which is stage 3 or 4, we use chemotherapy. And the most common treatment in the United States is ABVD, which is a combination of 4 drugs given once every 2 weeks, typically for 6 months. For early stage Hodgkin's, there's a little bit more controversy. And in fact, there's a tremendous amount of data out there suggesting that we can limit the number of cycles of chemotherapy we give and also limit the dose and the size of radiation that we give. So to give you an example, stage 1 or 2 Hodgkin lymphoma without risk factors, in those patients, because cure rates have been so outstanding, we've really tried to reduce the amount of treatment and still be successful. And current options for patients with early stage Hodgkin lymphoma without risk factors can be either 2 rounds of chemotherapy, 2 rounds of ABVD with radiation. It can be 3 rounds of chemotherapy followed by either observation or radiation, or it can be 4 rounds of chemotherapy with or without radiation, or it could be 6 rounds. So there's a little bit of a controversy over how to best treat early stage Hodgkin's. What's really impacted how we treat patients and how we choose the number of cycles has been the recognition that PET scans, when done early, meaning after a couple rounds of chemotherapy, are very predictive of how well people will do. And so by using PET scans, for example, after 3 cycles, this was a study done in England, we now know that there's a huge number of patients who don't need more chemotherapy if their PET scan has turned negative. Similarly, there are studies going on right now to see if we can limit the number of cycles of chemotherapy and maybe even avoid radiation for people if their PET scans have turned negative. So this is a moving target, but something where I do think over the next few years we'll be able to be much better about deciding how many rounds of chemotherapy and how much radiation, if at all, we're going to use for the early stage patients. So for Hodgkin lymphoma, when we look at frontline treatment, which is ABVD most commonly in the United States, the cure rates are very high, but not everybody is cured. And so when it does come back, we have a couple of options. The most common and standard of care option is to put people back into remission using a different kind of chemotherapy, what we call salvage chemotherapy, and if they go into remission, to do an autologous stem cell transplant. So for those patients where the Hodgkin's comes back, we do the salvage chemotherapy plus the auto transplant. And in the majority of cases, this is actually very successful. I think what's exciting is that most recently there was a study looking at the highest risk patients, those patients where the Hodgkin's had come back either within a year of their original diagnosis or never responded to their initial diagnosis. And this study looked at the use of a new antibody drug conjugate called brentuximab vedotin following transplant. And what the study showed is that those patients who got the brentuximab vedotin essentially had a much longer progression-free survival, meaning that they went much longer without their disease coming back. And I think trying to, one, identify who's at high risk of the transplant not, curing them or working or, having long-term remission, that's very helpful to know who those patients might be. And two, to have a treatment that can be given safely after a transplant is also a huge advance. Because Hodgkin lymphoma affects primarily younger people, we have a huge number of issues that are very specific to young adults. For a variety of reasons. One, when people are younger, we know that this is a highly curable disease, and so we want to think not just about our short-term toxicity, but also long-term. What's going to happen to them 20, 30 years from their 20s when they're still, very young people. We think about fertility, which is a really important topic, particularly for young people who are thinking about what their families may be like, at some point in the future. For men, it's fairly straightforward, and it is the standard of care to do sperm banking before starting chemotherapy. For women, it's a little bit more complicated, and there are options such as harvesting eggs or removing a part of the ovary and storing those eggs. But this is something that really has to be discussed with a fertility expert because when we do that, it does delay the start of our curative chemotherapy. So it's not always easy to have these discussions, but they need to occur, and I would encourage any patient to bring that up. One sort of very reassuring piece that came out not too long ago is that a study looked at infertility rates after ABVD in women, and it appears to be extremely low, maybe in the low single digits, particularly if a woman is young when she first gets the chemotherapy. I think anybody with any type of lymphoma, including Hodgkin lymphoma, should seek out clinical trials wherever possible. Clinical trials try to not only move the bar forward in terms of how we cure patients, but in Hodgkin lymphoma in particular, there are studies that are trying to reduce the amount of chemotherapy or even replace some of the chemotherapy with drugs that may be less toxic. And I would strongly encourage anybody with Hodgkin lymphoma to seek out a clinical trial. One of the most exciting new areas in Hodgkin lymphoma has been immunotherapy. What we've learned through scientists around the country is that there are certain chromosomal abnormalities in Hodgkin's that lead to certain proteins being turned on or upregulated on their surface. And what these proteins do, and the one I'm referring to is PD-L1, it blocks the immune system from recognizing the Hodgkin lymphoma cells. This is a really beautiful type of observation where for many, many years, whenever we looked at the cell gone bad in Hodgkin's, the Reed-Sternberg cell, it was always surrounded by these T cells, what we call T cell rosettes. And it wasn't really clear what these T cells were doing or if they were helping the Hodgkin's or not helping the Hodgkin's. What we know now through the work of many different laboratories is that Hodgkin lymphoma increases a protein on its surface that hides it from the immune system. And now with a whole new class of immunotherapy agents called PD-1 inhibitors and checkpoint inhibitors, we are beginning to understand that we can unblock this mask and lead to clinical response in patients with Hodgkin's. I think the Lymphoma Research Foundation is an excellent resource for people with Hodgkin lymphoma. Not only do they have a tremendous amount of information about the disease, but they also have wonderful support services, particularly for people who are in the younger age category, what we call the adolescent and young adult, or AYA category, but really any patient with Hodgkin lymphoma. There's a number of resources available through lymphoma.org.